Good afternoon, ladies and gentlemen. First of all, I wanted to express my privilege and my honor to share the podium with distinguished colleagues such as Dr. Sao, Dr. Bose, and Dr. Wurchek. And I also want to thank you for coming to this talk. You have many choices. You choose to come to us. And the last time I give a talk to a room packed, who packed the audience packed the room with a standing room only. It was many years ago. So. Dr. Jiao Sao opened the meeting, and Dr. Vos have given us a very good interview of the whole disease and the disease aspect of the disease and the overview, bird's view of the different therapies. She explained the mechanism of BTK inhibitors and the resistance and the mechanism of resistance and the clinical implications. Dr. Wojcik then gave two excellent cases, one on small molecule pirtobrutinib, another on cell therapy with brexabartine autoleucel. My presentation will mainly wanted to give some pros in clinical applications of those therapies. So we know that chemo-free therapies came from chemotherapy's evolution in mantle cell lymphoma in the relapse setting. And before bortezomib was approved, and it was all chemotherapy, we all remember those days. Maybe some of you remember these days of CHOP, hyperCVAD, methotrexate, ESHAP, and ICE, and many chemotherapies. Then the bortezomib was the first approved for mantle cell lymphoma, but the bortezomib is a proteasome inhibitor, different from many categories of chemotherapy, but it also have chemotherapy properties. It can induce severe thrombocytopenia and neuropathy. So I think bortezomib is half chemo-free therapy. So a lot of people don't like to use it anymore because it damages the platelet, give the neuropathy. So I wanted to express that one time I have a patient in the ICU, and the patient doesn't have a lot of, ventilated and he has a very aggressive mantle cell lymphoma with a lymphocytosis very high, like over 100,000 K. And the ICU doctor said, Dr. Wang, I think we should talk to this patient for palliative care and maybe send the patient withdraw the care. I said, just give me 1 day or two. I give the patient 2 doses of IV bortezomib, and the patient was in ICU, was properly prevented from tumor lysis syndrome. The patient had a dramatic response to the bortezomib, the single agent with improvement, and that patient actually was extubated and life saved for another period of time. So I often reserve the bortezomib to the patient who had refractory and with lymphocytosis. Please remember, and this is a very effective therapy in that case, and even the patient, my patient was on dialysis and he didn't have to adjust the dose. The VRCAP is a European and led by Dr. Cavalli, was a very good designed trial, but the trial was designed, published in 2015, so more of the therapies are changing. So in the past, we use R-CHOP, and then we have VRCAP, and then the VRCAP is not very popular in the US. Then we have in the Europe and the US, and then we have BR. And after BR, now we have acalabrutinib add to BR in the ECHO study, which is I think the global standard therapy. At least FDA approved it for in the US. So in the past was R-CHOP, VRCAP, then BR, and now is BR plus acalabrutinib, in my opinion. And so the next agent also have chemotherapy is lenalidomide. Lenalidomide is a cerebral binding protein, is an immunomodulatory agent, but it does cause cytopenias, and in randomized trials in myeloma, it causes secondary malignancies. So I really think that a lot of chemotherapy properties. But please remember, R2 is still a good regimen for the mantle cell lymphoma, and also a lot of people may not remember R2. R2, after 3 prior lines of therapy, the overall response rate is 57%. So if you used it early and you combine with the radiation to the Bucky sites, the response could be over 65, approaching 70%. The radiation with R2 is very synergistic in my practice. So I often use that in all the patients who run out of options. And then Dr. Vos categorized the 4 generations of BTK inhibitor. And so the first is ibrutinib, and the second was covalent, acalabrutinib, zanubrutinib, pirtobrutinib as reversible, and then the newest category is BTK degraders. Come to ibrutinib is the first agent, and this may be withdrawn from the US. And the first time I gave the talk in the audience at ASH many years ago, and the room was standing ovation 3 times during my talk. I have to tell people that let me finish my talk, presenting data. But you can see after 9 years on the market is withdrawn. So this is how our therapies has evolved. Sometimes could be a great agent, but it can be evolved. So the reason for the withdrawal comes from the SHINE study, and everybody had a great expectation for the SHINE study. Is like a 500 trial, international phase 3 trial with 38 countries participating after $100 million. But the primary endpoint PFS was very statistically significant. However, the overall response was overlapping, and because of this, and the trial did not help the drug at all, and so the withdrawn. I don't quite agree with the FDA on this particular point. Remember, SHINE is on older patient. The study population is over 65. If you, based on SHINE trial data, you want to withdraw the ibrutinib in the US, at least you should consider the age, right? In my opinion, probably it's reasonable to withdraw the drug in the US for the older patient over 65, but there was no great reason to withdraw the drug in the younger population, less than 65, and a lot of data. So, and ibrutinib has the main issue on the trial. The ibrutinib has an atrial fibrillation of 13.9 and grade 3 or 4, 3.9 centimeter. Percent of the atrial fibrillation, and also you can look at the infection pneumonia 33 versus 23, and grade 3 20 versus 14. Those are the main reasons. Is that ibrutinib was too toxic in older patients. And of course, never use, if you are able to use combinations, consider it when your patient is young and have a robust aggressive tumor. Please remember, radiation therapy, mantle cell lymphoma is a very sensitive radiation therapy. You can use radiation therapy to target the big tumors. So maybe use the combination. You take 6 cycles to achieve a complete remission. But if you use concurrent radiation, there's a synergy, and you could achieve complete remission in 1 or 2 cycles of such a combination therapies. So please remember radiation. I use radiation in my daily practice. So the combination, you can see that the rituximab ibrutinib published in the Lancet have an overall response of 88%. This is even higher than ibrutinib venetoclax obinutuzumab with 71%. Double agent better than triple agent. So please, it is. I think it is not the population was too different. Never compare trial across trials, because usually the 3 agent is much more effective than the 2 agents. Please remember, all you can see is doublets and triplet here. And I treated myeloma for 10 years, and I know that myeloma has moved to 4 drugs based on the clinical trials. I think in the future we might need to design more 4 or 5 drugs, maybe not concurrently, but maybe we use some in the induction, then in the consolidation and the maintenance, addressing different targets to address the heterogeneity of mantle cell lymphoma. The take-home message is please use combination. Don't forget radiation therapy. The triplet on the ibrutinib here by the French group, Dr. Lugano's group, and you can see the MRD is more than 50% and the overall response rate was high in 82% of patients when you combine ibrutinib, venetoclax, and obinutuzumab. So second, covalent BTK inhibitor is acalabrutinib. It's 81 response rate and 47. So it is more effective than ibrutinib. Actually, not true. Ibrutinib response is 70%, 69%, but ibrutinib study has 3 prior line therapy, and acalabrutinib has only 2 prior line therapy. So you cannot compare cross trials. It's dangerous because the study population and that. So in the covalent BTK inhibitor, we did a trial called ECHO study. ECHO study has exactly the same design with the SHINE study. They both have rituximab maintenance. They both including the BTK inhibitor, and that was given. So unfortunately, the SHINE study have the overall survival overlapping each other. Looking at the ECHO study, you can see the CR rate is a little high. The PFS rate is very significantly different. The overall survival, which is not in the slide, has a trend, but clearly separated trend over the acalabrutinib plus BR group. Therefore, US FDA they approved the study for frontline therapy in the US. So the FDA approved the 3 agent. What I see in the community is more and more oncologists are using 3 BR plus acalabrutinib. So the side effect, please remember, the key issue is that the atrial fibrillation you can see is what it was 13-point-some% in the SHINE study. Here it was only 6.7 with a secondary acalabrutinib. Infection was still a main issue, but it's much better than the SHINE study. So chemo-free therapy with AVR, and we were approved in the relapse setting single agent. We combined it, then we use AVR in the front line. The triple drug regimen also have a response rate of 100% in a very small study of 21 patients, and 71% of these people had a CR. And unfortunately, in this study, 5 out of 21 died from COVID-19 infections, and those people are all unvaccinated. So that's the next agent, the second generation was zanubrutinib, also have a very good response rate. Please remember, those are 1.5 prior lines of therapy. Of course, the PFS, if you used the BTK earlier, is very impressive here. And so the chemotherapy was also combined very effectively in a very famous Bowman study in Dr. South's department, headed by Dr. Anita Kumar and her collaborators in Boston. And this trial, the beauty of this trial, it only enrolled 53 mutated patients. The response rate is almost to the roof, 96%. CR is especially high at 88%. So many patients in the community, when they see P53, they use Bowman study. And I also use Bowman study at MD Anderson. I really think that this is a great study, and we need longer follow-up. Of course, we always hope for more patients. So then the pirtobrutinib, we relapsed only 50% response rate. Be careful with that. And the median PFS is only 5.6 months. We always remember, you're careful when you use single agent in this setting. And so what if the pirtobrutinib was used before covalent BTK inhibitors? Very, very effective. The overall response rate is 86%. Also 2 prior lines of therapy, and the duration of response was good when you used a little earlier. So the covalent BTK inhibitor, it also have different, so Dr. Warchek already explained this. I will go faster, and he already explained. So, we have a lot of combination therapies with pirtobrutinib, pirtobrutinib plus venetoclax in the relapse setting, glofitinib plus pirtobrutinib in the relapse setting, and the frontline study with the pirtobrutinib BR doublet, and also the triplet pirtobrutinib venetoclax. This is also a triplet therapy. Of course, our therapies are changing so fast. We had ibrutinib, venetoclax, rituximab. We into the AVR. That we have an even better Bowman study, and now pirtobrutinib, venetoclax, and rituximab is going to challenge the existing chemo-free therapies. Of course, the pirtobrutinib Bertinib, they always wanted to they want to see Bertinib was only 50% in the relapse setting. They want to try this study in the phase 3 clinical trial, comparing with the covalent BTK inhibitors, head-to-head therapy in BTK inhibitor naive patients. You can see Bertinib is on one arm, and on the other arm, you can choose any of the covalent BTK inhibitors as you wish. So therapy is ongoing, and the readout time probably in the early part of 2027. And another drug, named Bertinib, so far the single agent data is not published. You can see is in combination with xalovirtamine doting, the combination of the two induced a response rate of 64% in a very small number of patients, and we're waiting for more updates. And BTK degraders is very, very important, but like the rest of the drug development, the first might not be the most successful BTK degraders. You can see the earliest was the first trial in BTK inhibitor in relapsed mantle cell lymphoma patients. Unfortunately, on the left panel, the overall response rate was only 26%, and so it's not very good. And then they have a more specific BTK degrader. The trial is ongoing. So far, the response is 21%, only partial responses. Of course, the trial is ongoing. There's another drug called BGB-1673, it's a BTK degrader, and so far the single agent activity is not very clear. On this trial, you can see that 2 out of the 4 patients responded, and of course there's much more patient enrolled on this, and we are looking forward to share the updated data in the near future. So CAR T cells, brexpiprazole, Dr. Werchek has explained this. I really think that this is fit for the younger patients. The difference between the co-stimulations is that CD26, the T cell expands very fast, and they kill the lymphoma in the first week, 90%, and they achieved good response after 7 days, but it's very stormy. Their peak is very high, therefore CRS is 15%. And the neurotoxicity grade 3 or above is 31%. Grade 3 or above, that's very severe. I remember one of my patients who get a very bad neurotoxicity. The brain MRI was positive for brain edema. The patient was obtunded, intubated, and we have to, in order to reduce the cranial pressure, we had to do a ventriculostomy to drill a hole. And then we have to use the CAR T cells was not only attacked the CNS, was attacking the liver, attacking every organ with great elevated LFTs. And we have to use ATG, rapid ATG, which saved the patient. The patient was a lawyer from a state, a democratic state, and he was in charge of the party's money for a campaign. And I got a call from the senator, said, Dr. Wang, you make sure you save his life, and also remember where the money are buried. So, and fortunately, he survived the neurotoxicity. He's practicing law, and he's 5 years, maybe 6 years into remission. So CAR T cells is very powerful, but it could be very toxic. So Dr. Werchek already explained all this. I'll move on and to lysocell cell and CAR T cell therapy. First of all, I really think the population in this clinical trial is much more sick than the ZUMA-2 clinical trial. But why the response rate is 83%? Why the CR is even higher than the ZUMA-2 patient? The secret is in the conditioning therapy. While ZUMA-2 only allowed the steroids and BTK inhibitor, but this, the Juno trial, the lysocell trial, allowed chemotherapy, radiation, almost anything you want to do is reasonable. So if the most of the toxicity and the low efficacy is correlated very closely with the pre-infusion tumor load. So in the ZUMA-2, we was not able to reduce any tumor load. But in the lysocell, despite the sick population, why I call it sick population? Because the PFS in this trial was 15 months. You can see in the green on the right. However, the overall survival was 18.2 months. That means the study enrolled the near desperate population, because after the CAR T cell therapy, this CAR T therapy, there's patient only survived 3 months, not able to enroll any other clinical trials. So the patient, to many patients on this trial, that's the last therapy the patient got, right? So despite that, the bridging therapy was very effective. Please remember, in the mantle cell lymphoma, very different from large cell lymphoma. Large cell lymphoma is inherently refractory to therapies, but the mantle cell lymphoma, together with the radiation, is almost always sensitive therapies. We have a better chance with the mantle cell lymphoma than large cell lymphoma, T cell lymphoma, in decreasing pre-infusion tumor volume. So this is very true for this trial. And of course, the CRS with the CD28 as co-stimulated in the Zone 2 clinical trial with breast carbohydrate was 15% grade 3 or 4 CRS, but here only 1%. There is a dramatic difference. So because this is also approved in clinical trial, approved by FDA in the US, I used the breast carbohydrate for the younger patient. I used the lysocell for my older with high comorbidities, and I really have been getting good results. One of the other issues that there was 7 patients in this lysocell trial that had CNS lymphoma, and the response rate was 70%. So please remember, both breast carbohydrate and lysocell, they are effective in the patient even has MMD and mantle cell lymphoma in the CNS. So unfortunately, CAR T cells are so, we have so many targeted therapies. However, targeted therapy is not curable. They usually lose their power after 24 months also more or less. But CAR T cells is great. But in the US, only 20% of patients with large cell lymphoma got the CAR T cell therapy. But in the Europe, it's a little better, 30%. So although the CAR T cell targeted therapy is good, that overall they can reduce the tumor, but they don't last long enough. CAR T cells is curable potentially, maybe much less than large cell lymphoma in 10 to 15%. However, not everybody can get to the CAR T cell therapy. Why? The main issue is the cost. It costs too much money. Not only the patient have problems, the country system cannot afford this. So can we overcome this? Very slowly, because after 7 years, only 20 to 30% patients who should get the CAR T cell therapy actually got it in large cell lymphoma, probably even worse than mantle cell lymphoma. So I don't think there's any quickly we can fix this. Therefore, we must look into and CAR T cells, great, but not able to deliver that in the community. So we have to think about the bispecific antibodies, trispecific antibodies, the T cell engagers, and especially the combination of them. And this is very effective in our refractory patients. And I really think in the future, 70% of the community will be able to use the bispecific antibodies in the communities. So this is very, very important. In the past, we have BTK inhibitors, and after BTK failure, the overall survival is less than 1 year. Many trials, but less than uniformly less than 1 year. But with ZUMA-2 breast carbohydrate autoleucel, the overall survival was 48 months. So imagine 4 years. Imagine that less than 1 year, 4 years, right? Very, very good. And I think the bispecific antibodies combinations, then the BTK inhibitor can be rescued by CAR T. But what about the CAR T? Everybody having a hard time in the CAR T. So now we have much more therapies. We have the triple target therapies with the radiation all can induce a very high rate of response, but they don't last. But the most effective combinations of therapy, the bispecific antibodies, and in this, we have presented the combination of polatuzumab, CD79B immunotoxin plus mosunetuzumab sub-Q bispecific antibody. This combination was presented by Dr. Elizabeth Buddy, my colleague, and she will also present the updated data at this meeting. So I really think in the future, after the CAR T-cell failure, we have to mix everything. We have to remember the different targets, and where there's very different, also very bright different CAR T-cells coming with targeting different targets such as BFR, and we have dual CAR T therapies. So the therapies will change very dramatically. The number of bispecific T-cell engagers will increase dramatically as well. So many people ask Michael, when are we going to cure mantle cell lymphoma? First of all, we don't have a definition to cure mantle cell lymphoma. In large cell lymphoma, we agree that if a person gets large cell lymphoma and is got some therapy in the front line and had a CR more than 10 years, this patient is considered a clinical cure in large cell lymphoma. A lot of people don't know, but in follicular lymphoma, many veteran follicular lymphoma colleagues said, look, Michael, there's no good data, but if a follicular lymphoma patient has been in complete remission for 20 years without recurrence, that might be a cure for follicular lymphoma. In my opinion, and it's only limited to my opinion, we don't have data, mantle cell lymphoma, you at least need 15 years of CR to be called a cure. So if we use this surrogate guessing cure based on some of the data, so I would have to tell you 30% of my clinical population died of something else. But 10% of patients are still alive and after 15 years CR. And this is on the current status. So I did some window 1 clinical trial, did a window 2 clinical trial. So some of the window 1 trial patients had reached 11 years of CR without any other therapy. And maybe this patient, some of the patients can last for another 4 years, and they can be potentially called a cure. I really think we are in the process of curing mantle cell lymphoma. And once we have the cure, there could be nothing better than that. Thank you.